So I'd like to introduce our final speaker for the morning session is Associate Professor Haryana Dhillon. She's a behavioural scientist and psycho-oncologist at the University of Sydney, working with people who are living with cancer or working through cancer survivorship. Dr. Dhillon is going to talk to us today about portals and pathways. Can we deliver integrated support to people with brain tumours and their families? Thank you.
Thanks so much, Marina. It's lovely to be here. And hello, I've just suddenly realised since we've come back into real life how short I am. So it's a long way over the lectern, but hopefully I'll make it. So it's my privilege and pleasure today to be speaking about a program of work that we're doing, which is assessing brain cancer rehabilitation, assessment, interventions and needs. And I'm presenting this work on behalf of a number of people who I'll mention a little bit later as well. I'd also like to acknowledge the traditional custodians of the lands on which we meet, the Turrbal people, and acknowledge that I live and work on Gadigal lands in Sydney. Sorry, okay. And also that I grew up on Kamilaroi lands in northwest New South Wales, and I have a real passion and commitment to delivering equitable health services to people in rural and regional areas across Australia, which kind of forms the basis of my disclosures and the biases that I bring to some of the discussion that we'll have today. So one of the first things that I wanted to acknowledge is that we've heard some fantastic updates from our clinical colleagues about the work that's going on, what we've learnt about brain cancer and additional treatments for tumours. But what I'd really like to do is just highlight the fact that we have not really touched yet on what it's like living with a brain tumour and how much effort and work you put in as patients and caregivers and families, in addition to the healthcare professionals who provide clinical care for you. And so this is something that I think we probably don't talk about enough. And I just thought I'd like to highlight this as recognising how much effort you are all putting in to still being here and turning up to events like this today, but also to managing your care, which is often a full-time job for both you yourselves and the people who are caring for you. And we want to do something about trying to fix this, and I'd really like to acknowledge my colleague Georgia Halkett, who's in the room today, who has been systematically working away at identifying needs and making an argument for the fact that we actually need to improve access to supportive care services for patients with brain tumours for more than a decade now, I think, Georgia. So one of the publications that Georgia's put out recently really addressed that issue about the supportive care, the level of distress and supportive care needs that people experience over time. What we did was to conduct a survey with baseline assessments and then assessment of needs and level of distress at baseline 3 and 6 months, so over time, to see to be able to understand what that trajectory was. And what you can see here on the slide is when we looked at baseline distress, so how distressed were people when they were at the time they were first diagnosed, and then looking at how their unmet needs changed over time, so at 3 and 6 months. And you can see that people with low needs continue to have few or relatively or no needs in that area, but the people who had high need or severe needs at baseline continued along the same sort of trajectory. And so we're really wanting to highlight the fact that this was something that people were experiencing, but we weren't necessarily addressing very systematically in the way that the way that we're providing care. The other thing that was kind of interesting about this, and this is really not to try and understand it, but just looking at the patterns of how people sort of, again, tended to stay the same, or sometimes their needs increased over time across the course of that study in terms of whether or not they had needs that they needed help addressing. So we've undertaken this work also on the background of Cancer Australia's optimal care pathway for people with high-grade glioma. So we have a pathway that is intended to guide how care is delivered to people. One of the things that is really interesting to me about this is that we talk about these 3 steps in the optimal care pathway, which talks about prevention and early detection of disease. It talks about what happens when you first present with symptoms of disease and the investigations and the referral pathways that are required to make a diagnosis and treat, and the optimal treatment planning. But it doesn't mention anywhere here what happens to people about, or any guidance around what the supportive care needs are, or what the other requirements or things that people need to think about would be. So we do have, and again, just to highlight this in terms of the time frame, it's very focused on diagnosis and treatment, but not supportive care. We do have a mention, there is a section on supportive care, but it doesn't provide a huge amount of guidance on how to do this. But we do know that many people who are diagnosed with a glioma will have some general needs and will need screening and information. Some people will need a further referral, and some people will need very tailored interventions, and a number of people will need very specialised services to support them. But that's not really well reflected in the optimal care pathway. So one of the other studies that we undertook with Georgia through the Cooperative Group for Neuro-Oncology was really to look at what the pattern of services available are across Australia. And what we did was to survey the sites who provide care for glioma patients in Australia, and look at what resources were available to them. And the detail here is not really important, but what is important is that on this side of the line where everything's a bit blue or dark, this is the area where most sites have them, have a service available, and here it's where they're not very likely to have access to that kind of service. So what we know people have access to are the sort of standard things like clinical care coordinators, and social workers and radiation oncology nurses and domestic support at home. But we don't have very good access to the kinds of specialised supportive care that people might need, that might help people to be able to access rehabilitation services or the kinds of support that might help them to address some of the very specific needs that they have. So what we're trying to do with the work that we're undertaking at the moment through the BRAINS program is to really see if we can identify a way to provide that supportive care in a much more systematic and way to fill the gaps that we recognise exist in care. So the overall aims of the program of work that we're undertaking are really to deliver better survivorship care and supportive care to people affected by brain cancer, to try and improve our understanding about the frequency and the severity of symptoms and what the needs are in that population across the country, to develop models of care that will that ensure that care is delivered in a coordinated way to better support people and better meet their needs, and also to understand what the needs of the people who are caring for people with brain cancers are, and to really try and provide much better structured support for them as well. As Craig mentioned, research is a team sport, so there are lots of people who are involved in this program of work right across the country, so I just wanted to acknowledge them. And we were lucky enough to receive some funding from the MRFF Australian Brain Cancer Mission for a survivorship grant. And what I wanted to mention to you today in a little bit more detail is what we're doing at the moment about implementing a needs assessment for people with brain tumours. And really what we're trying to do here is to implement screening needs for people for distress and symptoms in routine practice across the country. We want to understand what those needs are for both patients and their caregivers across the duration of the brain cancer trajectory, so that we can use that information to guide us to referrals for treatment and additional rehabilitation and support, particularly within the community, and also to help us identify areas where we need to do more work to provide better supportive care interventions. The Psycho-Oncology Cooperative Research Group, which is an organisation that is leading this work, of which I'm a member, a number of years ago developed a clinical pathway for anxiety and depression. What that did was provided a structure on which to develop and implement information and needs assessment and to screening, which is then supported by referral to appropriate supports. And it used what we would call a stepped care model, which provides clear treatment options that are based on symptom severity, and also kept the more intensive interventions for the people with the greatest level of need. And we were able to implement that system across hospitals in New South Wales and demonstrate that it was feasible to do it. People would use it, they would screen, and also that you could flexibly tailor the services available to people to the specific hospital resources. What it involved was an online screening process, which could use either the 10-item symptom scale or the distress thermometer with a checklist. And if people had an elevated screening score on this, they then completed a screen for clinical levels of anxiety and depression, because this pathway was focused only on that. So what we're planning to do really is to take this and to adapt it for the brain cancer population, so that we're assessing for needs as well as distress in this population. What we also had to support the people working at the hospitals was a traffic light process to identify who needed very quick intervention, who needed to be contacted and provided support early. So we're also looking at trying to implement something like that would ensure that we're delivering care more effectively and tailoring it to the level of support that people need right then. And again, we have referral and recommendations that we're developing based on the data that had been collected as part of other studies that Georgia has also led, that help to tell us what advice people were given, where they were referred, and what the recommendations were made to them. And we've been able to then start to develop the pathway that would underpin our portal, so that patients will be more likely to be referred systematically to services that are available in their areas, and possibly even outside their areas if telehealth services are suitable and available as well, in a way that perhaps is not happening so much at the moment. And we will continue to build that and to continue to build the evidence for this kind of an approach to supporting people with brain tumours. So I mentioned earlier that we also had that the BRAINS program has a number of different themes associated with it, and a number of aims. And we do have a theme of work which is really focused on developing and evaluating interventions for supportive care interventions. And there are 4 that we're focused on at the moment. The TeleMass trial, and I think Matt had already referred to some data that will be coming out about the intervention that's part of this, which is looking at providing psychological therapy via telephone for patients and family members, either individually or together. And that trial is currently, there is a trial that's currently running at the moment that is continuing to recruit. We have the LATCH study, which is aiming to address the concerns that people might have about cognitive changes after a diagnosis of brain cancer. This is a cognitive retraining program or cognitive rehabilitation program that will start recruiting people over the next couple of months, with the aim to run their first groups in February 2023. The cognitive rehabilitation intervention is delivered by a telephone or via Zoom platform as a group therapy, so it's something that will be available and open soon. Recapture Life is aimed at younger people with brain tumours, so the population who are 40 and younger, down to the adolescent group, to really take a program that's been developed for the adolescent young adult population in general cancers and see if we can, what needs to be adapted to support people with brain tumours. And Restore is a program that, or a study that is evaluating or assessing the suitability of a self-management program for fatigue. So we know fatigue is a very significant problem for people who are being treated for brain cancer. And what we're doing here is taking an intervention that was developed in the UK to see whether it's suitable to run for people with brain cancer in Australia. So if you are interested in knowing more about this study, it's currently open for recruitment, and what we're wanting to do is to get feedback from people who are clinicians, carers and family members of people with brain tumour, so that we can talk to you about whether or not you think the material is suitable for use or not. You can also scan the QR code or contact my colleague Rachel Campbell, who is also sitting down at one of the tables in the front row. And I think I would just like to stop there, acknowledge again that this is a body of work that's being undertaken by many people around the country, and we're very grateful that we've had the opportunity to obtain funding from the MRFF to support this work, and look forward to sharing more news about brains with you in the future years. Thank you.